bleeding at home. And just to be clear about my disclosures, I've done consulting and advisory panels for Takeda and Genentech, have travel support and honoraria from Octapharma, and have equity in Doximity and do some work with some nonprofit organizations. And so the first thing I really want to take everybody through, because I think it's important to understand the interventions that we're going to make and understand why they may potentially work and why we start to combine different things, trying to hit different areas of normal physiology. I'm going to talk about an approach to bleeding. I'm going to talk a little bit about what I do when I'm teaching ER physicians, our own internal medicine residents, our hematology fellows, kind of what's your approach to bleeding and having one. And then I'm going to spend a lot of time talking about epistaxis. So who in here has ever had a nosebleed and has needed to try to figure out how to manage it at home to try to avoid going to the emergency room? It's incredibly common. I will be the first one to admit I don't have a bleeding disorder, but yet I get nosebleeds in the winter. So they're very common in people, and it's even more important to recognize and think about how to manage them in people who have bleeding disorders. And then talk a little bit about emergency management. What are the things that I do, make sure that we have in place for our patients within the Boston Hemophilia Center as we are crafting individualized plans. So the first and probably most important thing, and I feel like I'm blocking the screen on this side, but it's always have a plan with your hematologist. Make sure that there's a plan. Now, how that plan is documented and communicated may be different in every single center, but we're going to come back to this and think about what are the important aspects. So hemostasis physiology, I am not going to put up the whole coagulation cascade and confuse everybody. I have hematology fellows that struggle with that, so I'm not going to force everybody in here to do what I think about when I sleep at night and what I dream about. But the very first step in hemostasis is actually not primary hemostasis. You would think primary means that it's the first step. But in fact, the very first thing that the body does in reaction to blood loss and injury is to constrict the blood vessels down, to really try to limit blood flow into a specific area. And this is really to minimize just the volume of blood loss. So that's step one. Then step two is what we call primary hemostasis. And that's when the platelets start to come together to form this plug. The way I explain it to patients is think about you have your scaffolding. You got to put up scaffolding before you can really start to fix a wall, fix a damage to a structure. And platelets serve one of that role. But it's scaffolding with backpacks. So the backpacks bring a lot of other important things that are going to signal and tell the body that that's where the site of injury is. And then you get secondary hemostasis. These are the clotting proteins. Now, trying to explain clotting proteins to people who, hematology is very abstract. I use a lot of analogies in clinic and when I'm going through these talks. So I tell people these proteins, you've got probably hundreds of thousands of different proteins that your body makes to do different things, but you've got about 30 or so that are designed to keep the blood liquid and flowing, but to turn solid to stop bleeding. And everybody already knows what protein is and what it does and what to expect. So this is where I, in clinic, say, have you ever taken an egg and cracked it over a frying pan? And everybody says yes. And this is where you have the aha moment where I say, so what's in the egg white, it's clear and liquid, and then it gets hit with heat and it's triggered to turn solid and white. And it's protein in there that does that. Now we have proteins and it's not the same process of triggering with heat and all this stuff, but it's the same principle. So that's another step when we talk about secondary hemostasis. And lastly is fibrinolysis. This is where you're trying to remodel that clot. You're trying to dissolve it so that it doesn't get too big. You dissolve it because the area is healed. And so it's important to know that many of the medications we're going to talk about, particularly for the areas that are prone to bleeding, are helped by medications that block fibrinolysis, so anti-fibrinolytics. And so that's where we're talking about those medications in that step. So, this is a diagram that a colleague at the University of Utah created for an education program where we're actually talking about how to manage bleeding disorders in older individuals who are undergoing surgery and talking about what are some of the risks. So all of these proteins are on a spectrum of amount that we have. And if you're missing one, then you can be prone to bleeding of certain types. But this also helps us understand why this changes and why one person may be more at risk of bleeding on a particular day than they are in other situations. What else is going on in the body? What's changing these levels? And so this is why it's very hard to predict why some people bleed in certain areas and others who are related to them and have the same condition oftentimes have different experiences. So my approach to bleeding, this is what I teach physicians. The first step is history. Take a history. And it seems like it's annoying that you have to say that because we rely so heavily on things like labs and CAT scans and MRIs and stuff. But there's this adage in medical school that if you take a good history, that most of the time, if you think of your top 5, the correct answer will be in that top 5 as to what's actually going on, even of rare conditions. And so the history really does guide what we think about. And so is the bleeding primarily in the mouth, or is this bleeding that particularly affects joints? Is this bleeding that is coming only once they have surgery? They're fine. They never have spontaneous bleeding, but you do surgery and they're bleeding immediately in the operating room. Or is this bleeding that they're fine and it's 5-6 days later that they start bleeding again? That really starts to narrow it down for us to give us an idea of what's the type of bleeding, where in that vasoconstriction, primary, secondary hemostasis, fibrinolysis is it going to fall. And, the other thing that hematologists rely on very heavily is our lab testing, but you have to remember that lab testing is not perfect, and it's also very dependent on where you do it. It's dependent on what happened to that blood from the time that it was drawn to the time it makes it to the lab. I can tell you that, I'm having a big, huge fight right now about where lab specimens go. And, is it okay to transport a specimen across town by a few miles to a lab? Sometimes it's totally okay, depending on what you're testing. When it comes to platelets, I don't even like those moving within the same building. I'd like to draw them as close to the lab as possible and have them hand carried, not through a pneumatic tube system. So there's a lot of different things that go into lab testing for hematologists. When we look at some of these, you'll oftentimes see abnormal values. It's important to repeat those because of the fact that sometimes, again, it might just be a bad specimen. It may not have been kept at the temperature that it's supposed to be kept at. Or did something happen and the phlebotomist got distracted and the tube sat out on the counter for too long? How many people in here have ever had a bleeding time done to them? I'm going to raise my hand because I've had a bleeding time done to me, even though I don't have a bleeding disorder. Yeah. So a couple people in here. This speaks to the fact that bleeding times are really not great as tests, but for a long time, they are all that we had. And so as we've been able to learn more and get more sensitive tests, more specific tests, we've been able to use them. You would be hard-pressed in my hospital to find people that would be able to do a bleeding time if you ordered one. I'm probably one of the last people that's done it, and I haven't done one in about 15 years. And that's because you have to be trained in it. You have to keep up competencies. But we have much better tests now. And as we get more and more, we get further and further away from a bleeding time being a helpful test. So how do I treat bleeding? I've got up here the couple things that are most important: holding pressure, thinking about your ABCs, airway, breathing, circulation. And then we think about transfusion support. And I put over here in a different corner, in a different shade, coagulation factors, because they are critically important to the management of specific patients and critically important to manage in certain situations. But no matter what I do with coagulation factors, if somebody is bleeding and you haven't addressed the large laceration in their arm, the large cut in their arm, it's not going to stop bleeding. And so we talk about this in hematology as like anatomic bleeding. The bleeding is there because of an injury or damage to the blood vessel. And yes, coagulation factors are important to minimize that bleeding and to help control it. But you can't jump directly to them and ignore the other things which are going to be helpful. So we're going to talk a little bit about that. So I threw up here antifibrinolytic agents because there are two main ones that we use. So tranexamic acid and epsilon aminocaproic acid. Very long names with lots of letters, and so we tend to call it TXA. And the other one, we use its brand name, Amicar, just because it's easier to say. Well, sometimes for TXA, its brand name in pill form is Lysteta. Has anybody heard of the amino acids and things in our diet? Have you ever heard of something called lysine? Yeah. So tranexamic acid looks kind of like lysine, and it does work. It works in a way that, because of its properties that it shares with lysine, how it got its name, Lysteta, Lys for lysine. And so I'll tell you, my personal preference is if I'm given equal access to both drugs and people can take pills, I'm going to probably use TXA much more frequently. Why? Well, it ends up generally being fewer pills. It's fewer times a day. So for people that are having to take a lot of pills, it ends up being a little bit easier. The other piece to it, who in here has had to take Amicar? Who in here has thrown up because of Amicar? Myself. Yeah, Amicar is great and works very well, but some people have a lot of nausea, GI upset from it. I've had people who have the opposite, where they have it with TXA but not with Amicar. So that's why it's important to say, this is what I'm experiencing. And so these are particularly helpful for mucosal bleeding. And why is that? Well, if these medications are working in the area that's fibrinolysis at that end pathway, what do you think might be particularly active in the mouth? The fibrinolytic system. So the activity of those enzymes that break down clots are much more active in places like the mouth. There are a couple other places in the body that we tend to think of it as well, but this is why when we talk about bleeding in the mucosa, there's a lot of use for it. So you can do different dosing schemes. In the inpatient setting, we can give it intravenously. If you give Amicar, epsilon aminocaproic acid, intravenously, it doesn't last very long in the blood. So instead of like TXA, where you can give it as a big dose intravenously and then wait 8 hours and give the next one, you can't do that really well with Amicar drips. And so we do it as a continuous infusion, so it's constantly going into the body at a low level. What's nice is you can actually adjust that drip up and down, but this is stuff that we would do in the hospital. But what are you going to be able to do at home? We've got pills, we've got liquid. So liquid, there's the swish and spit that you can actually do, is particularly well for dental procedures. Thinking about it, I know that there's some pediatric hematologists in the room, and I treat on the adult side, so I don't have to worry about this as much. But think about trying to manage bleeding in the mouth of a 2-year-old and getting them to take pills and stuff. So it can be very difficult. And so some of these medications are great for that. And we will get creative, and I'll show you some for how we manage nosebleeds with it. So home infusion. As a hematologist, I was trained primarily as hematology and oncology. So everything I knew about home infusion was primarily around oncology infusions, people that would get treatment in the clinic and then go home for 48 hours to get chemo infused through a pump. And so it wasn't until I started working in bleeding disorders about 10, 12 years ago that I started to think about what are all the services available and how great it is to have nursing companies that can go out, that can do this, that can teach people how to self-infuse, how to actually, to do these assessments. And I've gotten to know a number of the home infusion nurses very well. I talk to them on weekends, and they've gone out to assess somebody, and they say, this is actually worrisome. I think they need to come in. And so I can have a conversation in real time and have somebody that I trust in terms of clinical exam because I've gotten to know them. That's one of the benefits of working in my center, and is having these relationships. Now, who else could infuse? Family and friends. A lot of people have been here, but I think that what happens is that there's a lot of focus in the bleeding disorders community on hemophilia A and B, and that's been the case for many years. Fortunately, this is evolving and changing, and our national organizations are becoming much more inclusive and supporting people across many bleeding disorders. And so my hope is that everybody with a bleeding disorder will have access to things like the summer camps and the family camps where you go and you learn how to self-infuse, and get that confidence. And so I can tell you that as a physician, I'm really bad at putting IVs in. And I have, seen 5-year-olds that know how to self-infuse who have no problem popping a vein in, or even telling one of my patients who's older and never learned how to self-infuse, like coaching them through it. So I think it's really great that we have this community, and you can make sure that friends and family know how to infuse, and also for yourself. So the National Hemophilia Foundation has some great resources in different sections. And so I took this from an education program called Steps for Living, and it goes through different ages and different aspects. And how do you assess that you are ready for something like self-infusion? How do you assess that your child is ready? What are the other things? So what other tasks does a kid do at home that shows that they're ready to start thinking about and taking on responsibility for their infusions? And so these are some taken just verbatim, making sure you have a clean work area. Hopefully it's quiet. I've, written letters to employers asking that they ensure that one of my patients has access to a quiet space so that they can infuse in order to remain safe on the work site. Wash your hands before and after infusion. I think, this is a no-brainer for, infection control. And we talked a lot about this during the pandemic, but washing your hands and making sure you're doing it for an adequate period of time. Wearing gloves, have a way to throw out your supplies after you use them to make sure that you don't contaminate the waste. Never reuse needles, never share needles. This is really important because I think this is one of the most dangerous ways in terms of bloodborne transmission of infections. And making sure that these needles go into sharps containers afterwards. Staying organized, make it part of your routine. Think about when you're going to do it. Kristen and I and my team, we just recently had somebody in clinic who knows how to self-infuse. This is for a different bleeding disorder other than Glanzmann's, but knows how to self-infuse, knows exactly what to do, but just doesn't really have a good routine with it. And part of our job during clinic was helping them figure out a time during the week to specifically infuse, knowing what their work schedule was, and said, let's try this for the next 3 to 4 weeks. And I want you to send us a message afterwards to let us know how it's doing. What should we try to adjust? What do we need to do? So make it part of your normal routine. Create the infusion schedule so it becomes habit. Keeping all your supplies in one place. It's hard enough to go on vacation or go on a weekend trip and remember that you've got all the things that you need to take for clothing and toiletries and packing your bag. And if you've got kids, packing their bags too and making sure you've got everything. And then you throw in there, we also need to have all of our supplies together. So some of the families that I've worked with have travel kits where they keep supplies, and everybody in the family knows where the travel kits are, and some of them are already pre-packed so that when they go away, they just pick up the kit, take their medications out of the refrigerator, pop it right in, and then they go. So that's another way to think about being organized at home. Keeping a journal is very important, at least some sort of log. There are a couple of different apps that are available, some that are available to allow me as a clinician to even look and get reports on them. I don't feel strongly about those right now. The most important thing, I think, is to keep a list. And so, some people do it on spreadsheets in Excel. Some people literally write it down on a piece of paper and they bring it in for their visits. It helps me, one, to look and see, are you having a lot of breakthrough bleeds? When are the bleeding events? How long did you need to treat? Oh, interesting. Okay, you have an injury, you need to treat, and you get done with one day, you feel much better. Okay, that used to be your history. Now all of a sudden you're needing 3 days in order to feel better. Why is that the case? Is there something else going on that we need to explore a little bit? So the other piece that's helpful with these is we do data tracking. We do a lot of public health surveillance work with the CDC and trying to better understand bleeding disorders. And the only way we know the burden of disease is pulling from some of these registries, but also for insurance companies. I really hate to say that one of the things that I have to do in my job is to fight insurance companies to get coverage. And one of the things that's very helpful is when I can sit there and say, here are all the breakthrough bleeds that somebody's having, or here's exactly what they needed. And then once we do start a medication and we do get approvals, being able to maintain that approval by saying, look, by doing this in prophylaxis, by doing these steps, we've actually kept them out of the hospital. We've managed to avoid bleeds. And so you've actually saved money as an insurance company. So that's another aspect of keeping your log. So for your home infusion, you need your factor replacement. You need syringes, sterile alcohol swabs, something to clean up your work area, and your needles and gloves. And so again, every single HTC is going to have different kind of lists of what you need and how to provide it. Infusion companies, especially as they're teaching, you can go through and help you make sure you have exactly what you need. Additionally, tourniquets, gauze, adhesive bandages, sharps containers, and the treatment journal. So I'm going to stop there. And before we move into nosebleeds, I just want to see what questions does the group already have that I can try to answer about just the general process of getting all the things together at home.
Can you share what a sharps container is?
Let's see. I may not even have the photograph. Okay. So a sharps container there's all different sizes. You'll see them in your hematologist offices in the rooms. They're usually red colored and they're plastic, and they've got something, they're sealed in a way that you can put stuff into it, but you can't pull things out. And what that's designed to do is take anything that is sharp, hence the name sharps container, like needles, broken vials, anything that would be a risk for cutting. And if you threw it into the regular trash, it would be a risk for the people who are collecting the trash to get stuck by something. And so they're small ones that you can buy. And when you close it off, it's sealed. And there are different ways in which you can dispose of them. Some pharmacies have opportunities for you to bring back sharps containers. Every single city and municipality has ways in which you can call to have them collected. And so people who give themselves a lot of medications involving needles tend to know a lot about it. So think about everybody who's on insulin for diabetes, for instance, always into these sharps containers to prevent injury, needle stick injuries.
Okay. But I'll just add this, Michelle Lambert from Children's Hospital of Philadelphia, that if you don't have a sharps container, you can use a thick plastic jug. So like laundry detergent container that's empty, or something like that, or from fabric softener, one of those plastic jugs that's really thick. And actually that is an acceptable alternative to a sharps container and can be disposed of in the same way as a sharps container.
It's a great point. And if you go on to the National Hemophilia Foundation's website on self-infusion, one of the videos actually does have a laundry detergent because it's nice, it's thick, and you can seal it off on the top. And once it's in there, it's going to be very hard to get it out. Yeah, great point.
So Nova7, of course, is the only approved treatment for GT. I know that quite a few people here in the U.S. actually have an access problem for it. So you did talk about how if you're keeping a journal and you're able to kind of keep track of your breakthrough bleeds and stuff like that, that can help you be able to get better access. But even just in our own personal experience, insurance just won't approve Nova7 unless we do platelets first. And my family itself is just against platelets, so we try to go a different route instead. So if that's the case, what would you suggest in order to have your doctor help you be able to get access to the Nova7 without having to go the route of platelets?
Yeah, it's a good point. And I will say I'm very clear in my notes. I'll actually show you a note of a patient later. Because there are so few people with GT, I didn't pull a GT clinic note because I didn't want it to be one of the patients that you people may know in the room. So I pulled one of my hemophilia patients, but the principles are the same. I'm very clear in there about the instances of the use. And I get on the phone with insurance companies and ask to speak with medical directors, and we file appeals and we go back and forth about it. I will say that I've been mostly successful by putting references into my notes about being very clear why we're doing it, and being very specific in saying this is FDA approved for this specific need, and so that other pieces, we're trying to avoid platelets for these specific reasons. Not just saying we don't want to do platelets. There are a lot of different reasons to not want to do platelets. But there are specific reasons to avoid platelet transfusions in people who have inherited bleeding disorders. One, you don't want to develop antibodies to the platelets that then make it harder to use platelet transfusion in the future. When you absolutely need to have platelets, you want to be able to reach to the shelf and use that in addition to your recombinant factor VII product. So that's one. And so I'm very explicit about that. Now, I write very long notes. And, sometimes, I write these notes, we send it off, and it's somebody who's checking off a box. And the insurance companies have put these layers in there. And this is where it also is important to get involved with groups like the Glanzmann Research Foundation, like the National Hemophilia Foundation, others that are doing policy advocacy work. So in addition to having your hematologist be very specific and finding out why was this blocked in this way? I've had people petition their employers to allow them to switch insurance because they can't get what they need. It's much harder to do that, but there needs to be an understanding amongst payers that we're not using this indiscriminately. We're using this for a very specific reason. And I think that's how I've been most successful at doing it.
So I was going to make a comment that obviously Dr. Connell is a strong advocate for his patients. And I think that is critical, is that you have a physician, a nurse, a team that you're working with that can advocate for you. It's not infrequent that insurance companies will deny this. And the bleeding disorder centers, hemophilia treatment centers like Dr. Connell works in and around the country are used to doing this and advocating for their patients on a regular basis. So it's important that you have a team around you that is capable of advocating for you and ensuring that you can get Nova7 in appropriate circumstances. And I totally agree that you want to reserve platelets for what the recommendation is for life and limb-threatening bleeding. It's not for nose bleeding, although nose bleeding can be life-threatening. For the most part, these can be managed with NovoSeven. So you want to try to reserve those platelets. And so having a strong advocate team around you is really critical.
So if you wish to home infuse and you don't do it regularly, chances are you're going to be administering NovoSeven because there's trauma. And so you yourself are worked up or your family's worked up. Are there any strategies of kind of keeping fresh with that infusion and being able to get in that vein when everybody's worked up and you don't do it regularly?
Yeah. So one of the things that we have done with our infusion companies is for people who aren't doing it as frequently, maybe it's been a couple of years and they're realizing, oh, if I needed to do this, I probably wouldn't be able to. Or maybe there's been a weight change and your comfort in accessing veins is different. We've actually asked nursing to go back out and do reteaching. And then, this is one of those great things about the local patient organizations that exist, the regional bleeding disorder organizations that have these camps where you can go and you can practice and be in a supported environment with a lot of people around you, and they have all the supplies and they know all the tips. This is a part of the reason why I also say it's important to have family members that do it, because all of us knows who's amongst our family is probably the most calm in the situation. If I had to stick a needle into myself in the moment of an ongoing bleed, it wouldn't be me. I know exactly who in my family wouldn't be allowed to touch me. But that's the thing. And sometimes it's good to know that you've got resources nearby, like a neighbor who's an EMT or a firefighter. But sometimes you're traveling and you don't know. And this is why it's important to make sure, one, that you have your supplies, but you take your factor with you. And so, when you get to an emergency room and you can sit there and say, I just need you to put an IV in me so that I can get this in. Now, granted, that sets up a whole host of other things and getting access to emergency room and all this, but it's an opportunity to try to troubleshoot around an incident.
I just wanted to speak to that because I've recently been in the process of learning to infuse my 3-year-old daughter. She has a port, so I have not yet gotten to the point where I access her port on my own for various reasons, given her age and things like that. But I do know that her home care nurse did provide me with kind of like a mock port thing for me to practice on with her Hubers. So I don't know if that exists for IVs and whatnot, but it's been a valuable resource because you're able to practice whenever you need to, kind of thing, without actually doing it on a human, and kind of building up your skill set and locating, the button, so to speak, in a chest, that type of thing.
It's a good point. I'm remembering now that, I practiced on a bunch of fake arms placing IVs as a medical student. And so it means they exist. And I just haven't even seen them recently in terms of ours, but it's a good point. And that point about ports too, accessing a port is a very different process than accessing a peripheral vein. And so making sure that you've got sterile technique is critically important, because you're talking about access right into the central bloodstream. But again, once you're able to access and a port and get veins on a toddler who's running around and squirming, the best people at accessing veins are usually pediatric nurses.
Yeah, even our home care nurse, she's very skilled in, she's been working 30 years specifically within IV nursing, and even sometimes she will miss on the first attempt at times if Mia's being really defiant and we're not holding completely stable. And so I often am I'm not even a medical professional, so if she misses something too, then obviously it's daunting. But maybe a goal that I work through. But at this point, even being able to when she has access to infuse has been like a game changer for us, at least for after admissions, being able to continue to stabilize her from home versus lengthier admissions.
Missing is okay.
Yeah.
I had to get blood drawn yesterday for something else, and the research tech asked me where, and I was like, this is the vein everybody tries, and you can try it. And if you get it, great. If not, we're going in my hand. I have a vein right here in the hand. And she was so nervous about doing it. And she went and got one of the research nurses to do it and everything. And they're joking. They're like, what do you do? So they didn't know what I did. I said, I'm a hematologist. And of course, then, they're like, oh, exactly. And
Like we're gonna.
and I said, this is why I always thought it was funny. As an intern, they would call me at 2 a.m. because 3 nurses had tried and couldn't get in line in, so they wanted the doctor to come do it. And I was like, do you want the person that does 1,000 of them a year? Or do you want the person that does like 10 a year? And so, yeah, it is a skill set and it has to be practiced. And but it's totally okay to miss. And even in the best circumstances, sometimes you miss and sometimes you get it and you surprise yourself.
I did just have a quick side question.
Yeah.
I know we were discussing like TXA IV versus like orally. So for context, like my daughter does take oral TXA 3 times daily, regardless of the bleed or not. But she often does have admissions. Now, during admission, do you think it's better to go the route of IV TXA if that availability is like there, or continuing it orally? Like, is there pros and cons to doing one way or another?
It's a good question, and I'll say for the most part, it depends on the situation in my mind. And again, I'll speak from an adult standpoint as opposed to pediatrics. But for people that are having a hard time swallowing, taking pills and whatnot, sometimes the IV is easier because then it just goes in IV. But for the most part, if somebody's already on something, I keep them on whatever their home regimen is because that's part of the routine and they know it and whatnot. There's certain medications, and fortunately, TXA is not one of them, where what we call the bioavailability is different. So certain medications where if you give it intravenously versus orally, it has very different amounts that make it into the blood. Right. So this one is fine. This is why I say, the big key thing is for Amicar, if it's done intravenously, it has to be done continuous infusion. If you give a big bolus of it, an hour or 2 later, it's already dropping off.
So essentially, like the half-life and like efficacy of it is the same.
Yeah.
Awesome. Thank you.
One other resource that I might point out that could be available to people is your local fire department or paramedic. It does require some pre-planning, and we had families that were able to establish a relationship, not in an emergency, but in a calm state, explaining the disease, getting to meet the family, getting to meet the child. And then when they needed to have a Novo-7 infusion, they were able to go to the local fire department. They already knew the family, they knew the kid, and they would be able to do the Novo-7 injection for them. So it's another resource that you can think about establishing. And it requires a note from the doctor.
I just had a quick question. We've had a lot of issues with trying to get Novo-7 or at least even approved for the hospital. They'll do it for like acute bleeding and then they won't do it any longer. And there was, appeals, doctor peer-to-peer and all that, and it kept on getting denied, and even for home use. And the way the FDA has it worded is for Glanzmann's is if you have refractoriness to platelets, to use, that's when you would use the Novo-7. We'd rather do Novo-7 and then, worst case scenario, if there's a major bleed, then maybe HLA matched platelets. Is there a certain type of wording that should happen when it's requested from the insurance company to be able to get it approved? I know that now we're switching to a new insurance come August 1st. They actually dropped our county. So we're hoping, like, once we're on the new insurance, to be able to have it worded correctly in order to get it approved for home use.
Yeah. Very good question. Every company is different. I think it's part of one of Dante's circles of hell. Whoever designed some of these ones. So I have what's in my note, and my note is very structured, and I'm very specific. And I then write sometimes a separate note and letter that goes into the chart, and then we update it every year because we know we're going to have to do the same fight. then there's also the forms that have to be filled out. So it's as much about what's in the note as it is about which boxes are checked on the form sometimes. So that, in my experience, because they're going to say, why are we doing something different than what our clinical algorithm says we should do?
Right.
And so having done this a lot, the main things I sit there and say, this is chosen for this reason. This has been the treatment plan and has been effective for the last 10 years I've been taking care of this person. We are specifically avoiding use of platelets unless there's refractory bleeding or life and limb-threatening bleeding in an attempt to avoid alloimmunization. So that's kind of the wording I use.
Okay.
Alloimmunization that would then prevent platelets from being effective in the future when they are needed. And so then I get into the appeals and speak to the medical directors. I will say that, I don't want to call out any one specific company, but I would say with the exception of maybe one or two companies, most have been very reasonable when I get on the phone. I'm talking to somebody. Peer-to-peer is often not hematologist to hematologist, let alone bleeding disorder specialist.
One of our issues too.
Yeah. So like one of the ones I had to do a couple of months ago, it was a hematologist oncologist who takes care of pancreatic tumors, was their medical director. And he's like, I haven't thought about this since fellowship. And I was like, okay, let's step through it. And I did it as a collegial thing of like, what would I do for my own colleagues that had their patient and they're asking me?
Right.
And at the end of it, he's like, okay, this sounds perfectly reasonable. Like this is not indiscriminate use. This is a very specific situation. So that's kind of how I do it in the stepwise fashion. For me, it's as much about getting somebody on the phone. Recognize physicians don't get paid for that.
Right. Right.
So I spent 90 minutes on the phone. We don't get paid for any of that. But it's necessary. And so, I can tell you as much as I do it, so does the nurse practitioner on my team. And she knows a lot of these people and she's dealt with a lot. And she can speak to this as much as I can. And so I know that when she's calling and sometimes doing some of these early steps, she's speaking with the same authority that I would. Mm-hmm. She participated in the trials that we did to get this done. As a complete aside, my favorite call, I think I tweeted about this once, is I called and they were adamant. This was one of the companies that I didn't go over so well with. They kept saying, we use the recently published guidelines. And that was how we made this decision. And I said, will you pull up who wrote that guideline? And of course, my name's the first one on it. And I said, so I would like you to explain to the first author on that paper, since you have them on the phone, why you disagree with them, even though you're saying that you're using my own words to justify your decision.
Right.
And, it's very embarrassing for them and all. We'll take this under advisement and whatnot. But recognize at the end of the day, most people we will get you there. It's just not fair that that's what you have to go through. So, so just bear with us as we go through the process with you. And took me 6 months to get somebody with severe hemophilia A onto Hemlibra. They absolutely needed it, changed their life. Haven't been hospitalized since, but it took months of getting it there. And so, and multiple denials. And so I just kept talking to medical director after medical director and finally wrote a letter to the head of the insurance company and said, I would need you need to, by end of week, personally respond to this and explain. And within 48 hours, I had an approval. But it was not the typical route. And unfortunately, there are people I haven't been successful with, and I've had to pivot and say, okay, they're not saying you can't use it. They're just saying they won't pay for it. So ostensibly, they're saying you can't use it. You can say it that way. So what are we going to do in the meantime? How are we going to address this differently? Okay. So there's now other recombinant factor 7A products. There's 7-Fact that's approved.
I did bring that up, but in order for them to use 7-Fact, they would have to change it for the whole hospital and use 7-Fact instead of Novo-7. And they've been using Novo-7 for even, the hemophiliac patients. And So they weren't, they're not able to switch. They said they can't carry both.
It's there's a lot of politics that go into it and whatnot. And there's a lot of discussions. I'm happy to chat a little bit afterwards about something too. So, if there are no other burning questions, I may kind of move on to epistaxis and get through nosebleeds, and then we'll kind of finish up with some more questions before you guys hit your break. So this is a diagram that I pulled, and I will sit there and use with medical students, and we'll say, this bleeding here, it's very scary. Looks it when it comes out, because it's right near the front, and you're talking about it coming right out, and you have arteries from above and below. These are not the ones that scare me as much as these do. The posterior bleeds, these are the ones where people lose airways. These are the ones that get packed and they start to bleed down the back and they need to be intubated. So, but all nosebleeds are scary, and all nosebleeds can be life-threatening. So I think it's important to recognize what are the steps that you take and when should you really get emergent medical attention. So there are many blood vessels that lie close to the surface, so they can be injured and bleed. My nosebleeds all come in the winter. I think I mentioned earlier, I grew up in Florida. So, I didn't have nosebleeds until I moved to New England and had the dry air of the winter. So I have a humidifier, I use nasal spray and all this stuff, and that certainly minimizes it. So these can be irritated by stuff that's up there. We all talk about nose pickings. So many people do it. Kids, it's, hard to avoid it with kids. It's just something irritating. And so the natural human tendency is to try to get at whatever is irritating you. But blood then leaks from the nasal cavity into the space and comes out the front and looks like a murder crime scene, or it goes down the back. And for many people who have nosebleeds, the smell of blood in clothes and the need to wash pillowcases every day, washing clothes. I recently was in a session and heard about a mother who said that the smell of blood causes her to become nauseous because she spent years washing clothes every day with it. So again, nosebleeds may not be classified by some as major bleeds, but they are very, very dangerous and hard to deal with. So what increases the risk? You've got so many different things. You've got the air temperature, trauma, if there's a cold or an allergy that's inflamed and now there's more blood flowing to the area as part of the healing process. Then you added things like low platelet counts and bleeding disorders. And so, again, we're talking about Glanzmann's fitting in here, but all of this contributes to it. So there's a lot of different things that you can do environmentally that aren't even bleeding disorder specific to try to minimize the risk of a nosebleed. So what do you do to prevent it? So I took a lot of this from our hemophilia center, particularly on the Boston Children's side, has this big handout that goes out to parents of the patients of how to prevent nosebleeds. Well, saline nasal spray a couple times a day. So you're less likely to have a break and start bleeding if the lining, the mucosa, is moist. If it's dry, it's much more prone to crack. And this can be bought without a prescription. Nasal saline gel, Vaseline, antibiotic ointment can be used right on the inside, especially if there's inflammation and potentially bacterial infections. Using the humidifier. So I tell people, put a humidifier on your side of the bed at night. And so that, it doesn't have to fill the entire room, but that way you're not breathing cold or dry air all night. And do it gently. You're blowing your nose, Everybody's got their own sound when they blow their nose, and everybody's kind of like, you can pick out your family member from a distance by how they blow their nose, but be the ones that blow gently and don't try to force it. If it's irritated and you feel like there's something that's up in there, it may be the clot that's holding things together. And if you blow too hard, you might blow that clot out. encourage children not to pick their noses, and then not taking medications that thin the blood. So everybody knows about aspirin. Everybody knows about ibuprofen and whatnot. We tell you to avoid those. The other things that I tell people to avoid, fish oil supplements, the omega-3 fatty acids, the fish oil that you get in your dietary intake is fine. But when you take these fish oil supplements where it's 10,000 times the amount that you would ever get if you ate fish 3 times a day for the next 10 years, you're taking large amounts. Those can act as natural blood thinners. So just be careful with those. Vitamin E is the other one, the large supplements of vitamin E, but dietary vitamin E is fine. Dietary fish oil is fine, but just not these large amounts. Make sure you're drinking plenty of fluids because that helps keep the entire area moist. Again, using nasal spray, you're hoping to get up into your sinuses, but the sinuses are a large area, and getting that, making sure that stays moist is important. And do not smoke. And if you can, avoid secondhand smoke. That's very irritating, and then again makes people more prone to having nosebleeds. So how do you control a nosebleed? And we just talked about, you're talking about a trauma or something. And what's the one thing that if you tell a person to calm down, that they don't calm down, is say, stay calm. What? You need to calm down. That never works, but try to remember that's your first step. In med school, there's this joke, there's a book that was written about one of the hospitals here in the 1960s and all these rules. And it says the first thing to do in a code is to take your own pulse. And that's important when you get there to recognize you have to be calm for other people around you to be calm. So first thing, stay calm and then sit up. I know sometimes it's irritating because you're laying down and you may have just woken up and you've noticed the nosebleed and it's onto the pillow, but you really want to sit up and you want to lean forward slightly. It sounds counterintuitive. The blood's coming out of the nose, so why don't I tilt my head back? The blood will just go down the back. And so if you, particularly with the, what we call anterior, more forward nosebleeds, having the head facing forward and pinching pressure at that site is actually much more effective than leaning back and letting all that blood continue to roll down the back of your throat. Breathe in and out through the mouth. Not everybody feels as comfortable with this, although I think a lot of people have started to realize how they breathe during the COVID pandemic with masks on and whatnot. And so people are much more attuned to breathing in different ways. And so being conscious and breathing in and out through the mouth and doing it slowly, because if you do that, it'll help calm you down as well. It also lowers your blood pressure, which then helps with the nosebleed. And pinch the bottom of the nose for 10 to 15 minutes. Watch the clock. Do not let go before 10 to 15 minutes. If I asked most people in this room to time out 3 minutes on the clock, pretty much everybody would short it by about a minute. And that's because we are very bad at telling the passage of time, particularly when we're stressed and we're having to focus on something. Think about, for everybody in here who's a parent and you've sent your child to timeout and you say, go to timeout for 5 minutes. And like 60 seconds later, they're like, am I done? Am I done? Yes, you need to, that's why clocks are very helpful. Not until the clock changes to this. So take a look at the clock, focus on it, and time your breathing with it. That will also help you focus and helps you calm down. Pinching the soft part of the nose. So there's the hard part up here. If you pinch that, you're not pressing anything because that's bone. You're not pressing anything on the inside. So pinching the soft portion of the nose is important. And, as blood drips out, you can wipe it away with a tissue to prevent it from dripping down onto you. The next thing you can do is you can take if that doesn't work, take a decongestant spray. I've got some in here that we're talking about. And you can put a cotton ball and right in there and then pinch for a full 5 minutes. Again, watching the clock, but you can't use these sprays for more than 3 days in a row. Why is this? Because if you use some of these sprays repeatedly for more than 3 days, you can actually get a rebound condition where the sinuses get congested and start to run again. So it can actually make things worse if you're using them continuously. And then if these steps aren't working, then you really need to start thinking about the emergency room. So what are some of the other ones? I will say, I've used Afrin in people. I've used these nasal seats, these actual packings you can buy over the counter. Who in here has ever heard of or used salt pork? So I will be honest, I've never used it. And I was thinking, okay, who designed this teaching sheet for my hemophilia center? And I decided to pull the data. We'll show it in a second. But you want to blow gently before you use these to make sure if there is something obstructive up there, you can get it out. And then you have a clear space to kind of put these in as wedge. And they help with the pressure activity. And you may need to use multiple treatments. So we'll get to salt pork in a second. So here's Afrin. It's really approved for over the age of 6. Don't use this for more than 3 days in a row, and 1 to 2 sprays in each nostril. It helps with what's before primary hemostasis, the actual first step, vasoconstriction. So this helps with vasoconstriction to prevent blood from flowing to these areas. So here's salt pork. So you have to prepare it in advance. I learned all of this in preparation for Glanzmann. So thank you to the foundation for inviting me, because I never would have known this. You can buy it in the grocery store. It's packaged like bacon, and you get these small pieces and use thread or dental floss and wrap them in wax paper and put them into the freezer so that when you have them, you take them out of the freezer and you place in the nose with the string hanging out for an hour. And I was like, is this a real thing? Like, there's like the things that work and the things that the community talks about, and then it's like doctors have never heard of this. Like, this is a publication from 2011 in a medical journal about using cured salt pork specifically in people with Glanzmann's, and that about this working. So I was like, I have to share it. There are so few papers specifically about treatments in Glanzmann's, and this is one of them. So this is helpful, and I'm glad to hear that people have heard of this, and all of you are thinking I'm a crazy person standing on this stage. You people have actually used it. Nasal cease, it works well as first aid for cuts and nosebleeds. All of these are different things that have gel matrix or a chemical component that causes coagulation to occur and can be packed up into an area to try to assist with hemostasis. And so this, you twist the end of the pack into the bleeding nostril. You only leave it in for about 30 minutes, and you have to apply pressure and ice after the use again, because you're still a lot of inflammation in those areas. These are collagen sponges in Helostat. They can be cut into the size of the area that you need to use them. These are absorbable, and I'm always a little bit nervous about something that you leave in. But the way it's described and used is that you should leave it in because it will dissolve and absorb into the area. For anybody who's had an ER doctor place, they call them rhino rockets, those packets, all this stuff there. And then what do they send you home on? Antibiotics. Because think about the risks. You've got a big area that's full of blood and it's exposed to the outside, which means exposure to bacteria. I suspect a lot of people in here who have grown up with menstruation and have had to use tampons have seen the warnings on the boxes about toxic shock syndrome. It's the exact same issue with leaving a rhino rocket in place for too long. And so bacterial infections leading to toxic shock. So, but these are designed to dissolve pretty quickly. And so I have a few patients who have used these in the past successfully. Again, pressure and ice afterwards. Then what can you do? So you can actually take liquid forms of the antifibrinolytics and soak it in gauzes and get it in there. And so these can be very helpful to get the TXA into a specific area if you are not taking it systemically, for instance. So this you remove after about 20 minutes, pressure and ice. So again, as you hear, anything you put in, or all the stuff you remove, again, it's pressure and ice after you've taken it out to try to control it. If these don't work, you should be going to the emergency room. You should be talking to your hematologist on call and with a plan and what to do. So what are some other things? If the bleeding cannot be stopped, if the blood loss is a large amount. Now, granted, there's a lot of blood that happens with a nosebleed, and it can be quite dramatic. But some people are like, yeah, I feel fine. I've had this happen to me a million times. I know. Or all of a sudden, wow, this is a lot more than I usually have. If that's the case, it's always safer to go to the emergency room and get evaluated. If you're feeling faint, lightheaded, dizzy, you stand up and you have these symptoms, that's a sign that you've actually bled enough that your blood pressure is dropping. And so those are things that you might actually need more interventions. You may need an ENT doc to go in and cauterize the vessel. You may need a blood transfusion. And there are a lot of people who say you can't bleed enough from your nose to need a blood transfusion. And anybody who's treated bleeding disorders knows that it's not true. And everybody who has experienced and has family history of bleeding disorders knows that that's not true. If you're vomiting blood or coffee grounds, people don't realize that the dark black material is when you bleed and it gets digested in the stomach, it looks just like coffee grounds. So if you vomit and it looks like that, that's a sign that you need to get to the emergency room. And if there's trauma, if there was a trauma to the face, like baseball hitting or something like that, playing sports or, an injury and then nosebleeding, that could be a sign that there's actually a fracture. And again, if I don't get control of the pressure in the site and the airway, control the bleeding, the breathing, and the circulation, I can make them have normal clotting factors all I want, but I'm not going to be able to control that bleeding with Novo 7 alone. So emergency treatment plans, I'll do this and then we have some time for questions. So this is what I was mentioning. So this is an example of a chart. And in our chart, when you come into the emergency room on the side, it's got name and information, and then it in bright pink, there are these acute care plans in our chart. And so when you click on this, this is what comes up. Severe, in the case of my patients with Glanzmann's, would say Glanzmann's Thrombasthenia. I oftentimes write a little bit more about what that means because people may know hemophilia A and B, but some of these they don't know. Needs immediate treatment upon arrival to the ER. Triage to be seen urgently. Treat patient immediately with this product. Do not delay treatment for radiologic imaging. If somebody has come in with a bleed and they've had a head trauma, I tell people, the ER docs, don't wait for the head CT to decide if you're going to give them that or not. It could take you an hour to get a head CT, and think about how much bleeding can happen. It's better to treat and then figure out what's going on. And then I kind of have these different pieces, and then call hematologist, on-service hematology fellow. And that this plan was approved by myself and our nurse practitioner on the team. Now, in my note, so they click on that, that's the emergency treatment. In my note, I have all this information in here about their treatment, what they should be getting, specifically their doses, orthopedic status, other things. And then that same information is in there. So I have it in multiple places in the chart to try to make it as easy as possible for people to find it. So for my patients with Glanzmann's, it's very specific in this treatment as needed. It says recombinant factor 7A, Novo 7 or 7-FACT, because I want to say which, I don't want somebody to walk into an emergency room and they're being told, oh, we don't have Novo 7. We only have 7-FACT, so I can't give it to you. No, I have this very clear in my plans, what their dose is upon immediate arrival. So that's where I'm very clear about their treatment plans. But to the question about what do I put into notes, it's oftentimes down here in this assessment and plan, and I will say, platelet transfusion is reserved for life-threatening or limb-threatening bleeding for these reasons, and have the relevant references. And if there's something specific that, for instance, the National Hemophilia Foundation's Medical and Scientific Advisory Council, MASAC, has come out with, I will even put the web link to it in my note to be as clear as possible that I'm not just making this up on my own. This is either evidence-based or it's expert consensus based, but it's not just me by myself coming up with a plan to spend the insurance company's money. So I'm going to finish there. The one other thing that I will say is, in addition to this information, I have all my patients, we give them letters, emergency letters, so that they can carry their factor on planes and cross borders and stuff like that. I've had patients climb mountains. I've had patients climb Mount Everest. And, they carry their factor and they've got letters, and, we've joked about translating into languages of where they're going to go so that they have it. But we give them wallet cards. A lot of people don't like wearing the bracelets or the necklaces and stuff like that. And if you like it, that's great. That's fine. I've started telling people, because everybody's got a smartphone these days. So both the iPhone and the Android have the ability to set it up that EMTs can access critical medical information without unlocking the phone. So if you want them to be able to have that. So for instance, on mine, pressing power and the up button gives you the power off and kind of emergency call. But in the middle there's medical ID. And just swipe and it pops right up. So I tell my patients, put their information there, put my pager number in there, so that if something happens and people need to get a hold of you and you're unconscious or something else is happening, they can access this without you needing to punch in your passcode or do Face ID and all that stuff. I have no idea how to do it on the Android. There's a way to do it. We're trying to put together an educational PDF on our website about it. But for a lot of people, it may be the best option if they don't like wearing the bracelets and stuff. So I'm going to stop there and see if we have any other questions. And I'm very excited because I think my colleague, Dr. Battinelli, is in the audience, who will be speaking to you.
I think they're right outside.
Outside. So,
surprisingly, I have another question. We haven't met yet, I don't think. I'm Taylor. I'm actually the president of the Glanzmann Research Foundation. So we actually, in my family, use, and my sister, she's going to kill me, is sitting right here. She actually self-manages and packs at home. And so one of the things that my mom and my dad have kind of let the community know throughout the years, and what has worked for her, and everybody in here who's part of the Facebook community knows exactly what I'm about to say. So what works for us is we actually are able to get Fibrillar or Surgicel and use that. And so she will either soak that in, you have epinephrine, don't you? Or Afrin, depending on what she has access to. And that typically, because her nosebleeds are higher up, and so she'll end up just kind of packing that and then just keeping an eye on it and letting, us know if it's looking like she needs to go in or something. But the biggest thing that I think a lot of people in here have had problems with in the past is they go to the emergency room and they try to do a rhino rocket. And then as soon as that comes out, that nosebleed is now twice as bad as it was when they walked in. And then those parents now in an emergency situation are having to not necessarily argue with the doctor, but also say, no, it's not going to work. Like, we've done this before. And then they end up getting convinced by that doctor, oh, no, let's just try it one more time. And so what could have potentially been handled has now turned into an even bigger emergency. Now we're seeing hospitalizations, posterior nosebleeds. So I think my question is, is there a way where, I know you have the notes and your clinical notes, but is there a way to kind of avoid that whole initial, oh, let's just do a rhino rocket? Because once it gets out of control with GT, you're just on for the ride.
So this is where I personally lean very heavily on our ENT docs, the otorhinolaryngologists, because one, I would never myself feel comfortable with a suggestion for a higher packing and all this stuff. It's not my area of expertise. You know, I haven't looked up there with the fiber optic cameras to know the anatomy and whatnot, but having an ENT who's been there and says, actually, this is what you should do, and having them put it into writing or even a card. And, you know, I can tell you that I joke, my best friend's an ER doctor, and I joke that I'm not smart enough to be an ER doctor because they have to be a jack of all trades and master of all. Like, it's not just knowing everything in medicine, but it's everything in medicine, surgery, pediatrics, obstetrics, all of it. And so one of the things that's very effective I found in discussions with emergency doctors is if you have something on a card as your emergency instructions that says, do not do this, then they're much less likely to do that. So, but on the flip side, when I'm getting a phone call, so say I send somebody to the emergency room and I get a phone call, I have to also trust the person that's on site. So this is oftentimes why I send down one of my colleagues, whoever's on call, or our fellow, to say, can you go lay some eyes on them until I can get down there in an hour? You know, next week, I keep referencing Dr. Banelli, who's here. She's on call next week. So she'll call me from the emergency room she's seeing one of my patients, and she'll say, this is what's going on. This is what's bothering me. And we come together with a plan. And the same thing with the emergency room. I can be very forceful on the phone about X, Y, and Z, do not do. This is the risk Y. So if you and your ENT have come to a decision, that's why the very first slide on there is about come up with the plan with your treatment team. Is if you've jointly come to a plan that a rhino rocket is not going to work, or if you're going to do a rhino rocket, you need to administer another dose of recombinant factor 7A immediately prior to the time of removal, and then place antifibrinolytic directly topical. That can be very helpful. The more explicit the emergency care plans are for somebody, the better, in my experience. Again, the ER docs have something else that the ENT and ER are the only ones that are allowed to prescribe topical cocaine to actually use it, because it works very well as a vasoconstrictor and to control bleeding. But again, you have to be very cautious with it, and so it's highly restricted. Again, I'm a hematologist. I'm never going to be the one to suggest that we try topical cocaine. But if I've got people who have the experience that I've collaborated with and worked with, and we've come up with this plan, everybody agrees on it, then that makes it easier to walk into an emergency room in the stress of the event and manage it.
Maybe I'll not be so kind to the emergency room doctors. So I have many friends that are emergency room doctors. And, you know, one of the things that I think it's important to educate patients and families that have these kinds of complications is the mindset of the emergency physician. So this is somebody who's dealing with a person having a heart attack in one room, another person who's got a blood clot, another person whose arm is maybe hanging off, and then you bring yourself or your kid in with a nosebleed. And in the general scheme of things, the nosebleed is trivial to, you know, these other things to them. And they're going to take the path of least resistance to take care of your problem, which is exactly what has been suggested, which is, you know, push that rhino rocket in, takes care of their problem immediately. It creates a huge problem for you maybe later. But I think, you know, one of the things that we encouraged our patients to do is stay out of the emergency room. Unless it's absolutely necessary, don't go to the emergency room. You know, call your physician, call your treatment center, work with them. You know, emergency rooms are dangerous places, just like hospitals are really dangerous places to be. And if you could avoid being in the emergency room, that's a good thing. So whatever you can do to manage your bleeding at home, that's the best place to be. It's the safest place because you control the circumstances. If it becomes a situation where you can't control the circumstances, then by all means, you need to go to an emergency room. But you have to be prepared to be, again, your strongest advocate to make sure that you get what you know you need to have. Don't let doctors, railroad you into something. You have to consent to these things. So they just can't do it on you or your child.
Well said, Dr. Valentino.
One other thing that I'll mention is we had a number of patients who either because of religious beliefs or whatever were against using salt pork. And so I've had 35 years of using salt pork. It's extremely effective. But we turned to creating nasal tampons. So we had patients so if you look at the size of your little finger, that's the size of the inside of your nasal cavity. So you can create a tampon that's the size of your little finger, your child's little finger. We use gauze pads, wrapped them with dental floss so that there was a string to pull out, wrapped them in Vaseline, and then use those to create a nasal tampon for yourself or your child. It's extremely effective, works pretty much like the salt pork. Salt pork also has an astringent in it. So not only does it provide the compression, if you freeze it, it provides the coldness that vasoconstricts the blood vessels, but there's a chemical in there that also constricts the blood vessels. So it can be extremely effective, but nasal tampons work equally well.
I love everything I'm learning about salt pork. My whole team is going to look at me crazy in clinic next week when I suggest salt pork. Yep.
The young sprayed said they can counter production after a few days. That's true for the gentler staining sprays or just the afrin?
Just the things like afrin. So it's oxymetazoline, but there's a whole group of them that are similar kind of in that family, that it's just a rebound effect from using it, which can make it much worse. But saline nasal sprays don't have that.
You could do it every day to get it.
Thank you. So mine is more like a suggestion for the moms of younger kids. There's already 17, so she knows a little bit more what to do. Going to college, daycares, we always had the nose bleeding kit. So it'd be like two little, containers of tissues, that good quality, because those rough ones were tough. A plastic bag with gloves, and the pinch thing, for the nurse, I was to work at the school, so it was easier for me just to come and help. But if she was in a different place, and she was bleeding one time for 5 hours, and then that's where we take her to the hospital because I couldn't leave my campus to go to her campus.
Yep.
So those things will help. Go to any place you go, take that little bag with you. It's the nose, and younger kids have an iPad or something to distract them.
Also, it helps. I bring those full packs of tissues in that plastic bag to school every day in my backpack. And usually at school, they have the worst tissues ever. So if you have that, even if you're just having a runny nose, it's really convenient and it's good to have even if you're not having a nosebleed.
And it potentially prevents the nosebleed because you're not irritating it with the other tissues. So great idea to have it packed in advance and know about it. And if you don't mind me asking, do you have a couple of friends who know about it? So just in case things get really bad, they can help you with it?
No. Yeah. So I just, if I think it's bad enough, I just go to the nurse, but usually it's not. So I just deal with it myself in class and kind of just sit there and nobody cares. So
yeah.
Yeah.
The other thing I do, I don't deal as much in pediatrics, but one of my colleagues in pediatrics just literally gives out notes and says, if there's any bleeding in anybody, they don't have to have a bleeding disorder. They should be able to go to the bathroom. So that's my little soapbox about bathroom restrictions in high school.
Thank you very much, doctor. Great information. I was diagnosed just last year that I have GT, so all this stuff is new to me. How about turmeric tablets? Can we take them? Or
I'm sorry, which tab?
turmeric?
Oh, turmeric. I've generally said to avoid it, but I'm not entirely certain on the data. I'll be honest with you, I don't know. But that would be something that I would end up looking at specifically. But it's a good point about, I tend to think more of things like, fish oil and vitamin E, these supplements. But So that's definitely something to either check with your hematologist specifically. The other people who are really good at kind of looking at these things and interactions are pharmacists. And so I rely heavily on our pharmacists for kind of over-the-counter supplements and understanding what's actually in a supplement. Because sometimes what's labeled on the outside is the supplement, because there's not the same level of regulation that the FDA has. So those, just because it says turmeric on the bottle doesn't mean that it's 100% turmeric. There could be a lot of other things, or there could be no turmeric in it actually at all. So making sure you know what's in it, and then having your hematologist do that. I do that all the time. I get screenshots through the patient gateway, and I sit there and send it to our pharmacist and be like, what am I missing? Anything in here that I've got to worry about? I don't see anything, but can you... And I'm always surprised at what I learned about specific interactions. Wintergreen. Okay. Right. Well, we are at the end of time. So thank you for coming today.